Hi there, it's great to be here with you. My name is Michael Shapiro. I'm a cardiologist at Wake Forest University, where I direct our Center for Prevention of Cardiovascular Disease. And I see a lot of patients with acquired and inherited cholesterol disorders, including individuals with familial hypercholesterolemia and elevated lipoprotein(a). And for today's AMA, we received a lot of really great questions regarding statin safety and potential for side effects. So without further ado, let's get to your questions. Well, statins work by blocking a key enzyme in your liver that helps to produce cholesterol, and this lowers the amount of LDL or bad cholesterol in your blood. So the end result is that statins can help prevent cholesterol buildup in your arteries, and they really represent the safest and most effective way to lower cholesterol and to reduce risk of heart disease, namely heart attack and stroke. Well, statins themselves do not interact with receptors. They are small molecules that get into your liver cells and inhibit the production of cholesterol, again by antagonizing one of the key enzymes in cholesterol synthesis. And as a result, the liver cells sense a reduction in the amount of cholesterol that's within their cells, so they produce more of a protein called the LDL receptor. The LDL receptor is basically inserts in the membrane of your liver cells, and the outer portion of that protein actually sticks out into the circulation and has the ability to bind LDL particles that are in your bloodstream and internalize them into your liver cells. So although statins decrease the production of cholesterol, their main role in lowering cholesterol levels is by binding to LDL in your blood and bringing it within the liver cell where it can be repurposed depending on the needs of the cell. But it's basically clearing LDL from your blood. Well, I would actually say they have more in common than they have differences. These are the two most potent statins, with rosuvastatin being slightly more potent than atorvastatin. So these two statins have the longest duration of effect, which is quite nice for patients, because if you miss a dose here and there, it's not going to really have a material impact on your cholesterol levels. Rosuvastatin tends to have a little bit less in the interaction with other medications, just because of the way it impacts metabolism. Atorvastatin, on the other hand, is generally favored in individuals with kidney disease. It undergoes metabolism in the liver and really has relatively low kidney excretion. So this means that the drug's clearance is not significantly affected by reduced kidney function, making dose adjustments really unnecessary in patients with chronic kidney disease. Again, I don't want to overstate any of the differences because they're more similar than different. And I would say they are generally the two most favored of all the statins amongst cardiologists because they're the most effective in reducing LDL cholesterol. Absolutely. Studies have indicated that even low doses of statins can meaningfully cut your risk of heart attack and stroke. And of course, lifestyle factors like diet and managing other health conditions can also impact your overall risk. But it is important to understand that the degree of cardiovascular risk reduction is generally commensurate with the amount of LDL cholesterol reduction. So while low-dose statins are certainly effective, generally we're going to get more risk reduction with more LDL cholesterol reduction. So higher doses or higher intensity statins tend to give somewhat more risk reduction. But the difference that's more important is taking a low dose of a statin versus no statin than a high dose versus a low dose. So it's just more important that we can get at-risk individuals on any dose of any statin they can tolerate. That's the most important thing. The short answer is no, absolutely not. It's actually the opposite. Statins have multiple beneficial effects, including anti-inflammatory actions. In fact, the anti-inflammatory properties of statins may be one of the reasons that they actually provide benefit in cardiovascular risk reduction beyond just their cholesterol lowering capabilities. So I would say that statins are actually anti-inflammatory drugs, and they do not cause long-term increase in inflammation. Yeah, this is a really important question, and I would just say at the outset that statins turn out to be one of the safest of all classes of medications that we have, and that turns out to be true for the liver as well. It's not uncommon for statins to cause an elevation in liver enzymes, namely two enzymes called ALT and AST. Statins tend to cause an increase in ALT more so than AST. But these elevations are usually quite mild and often return to normal even with continued statin use. In clinical trials, elevations of liver enzymes greater than 3 times the upper limit of normal have been observed in a very small percentage of patients. And in this scenario, the statin dose can be lowered, the statin might be changed to another one, or the statin may be discontinued, or other LDL lowering drugs can be used. It's important to know, though, that severe liver injury due to statins is extremely rare, on the order of about 1 in a million. And when it does occur, it's typically within the first few months of starting the drug, and it's believed to be an idiosyncratic reaction. Now, many people may remember the days in which doctors were testing liver function tests all the time. That's because guidelines in the past had recommended routine liver function tests before starting statins and periodically thereafter. However, due to the low risk of liver injury and the observation that routine monitoring didn't seem to prevent the rare cases of severe liver injury, the guidelines have now moved away from regular enzyme checks. Your doctor may still check your liver enzymes before starting a statin. If they're normal, then they really don't need to be checked again while you're on the statin. But even in individuals who may have mild elevations in liver enzymes before they start a statin, that wouldn't be a reason not to start a statin. It just may mean that periodically your doctor would have to check your liver numbers. And it's important to understand that people with chronic liver disease can still be treated with statins. It just requires a little bit closer monitoring. Well, this is one of my favorite questions and something that I talk about with patients all the time. But first, before we get into the specifics of the question, let's just do some level setting for those of you who may have not had a lot of background in coronary artery calcium scoring. Coronary artery calcium, or CAC, CAC, is actually calcium that we see in your coronary arteries, your heart arteries. So a CAC score, coronary artery calcium score, is really quantifying how much of that calcium is in your coronary arteries. And the calcium that we see present in your coronary arteries is very significant because it's a specific indicator of coronary artery disease. In other words, it's an indicator that cholesterol plaque is present. Your coronary arteries do not spontaneously calcify. So if we see calcium there, we know there's some coronary artery disease. And this is extremely useful in helping to predict an individual's risk for future heart attack. The higher the calcium score, it means the more cholesterol plaque that's present. And then, of course, the more plaque that's present, the greater the probability of a future cardiovascular event, like a heart attack. Now, statins do not reduce calcium deposits in the coronary arteries. So if somebody has an elevated coronary calcium score and then starts a statin, a repeat calcium score will not show a reduction in coronary calcium. The CAC increases inexorably, whether you're on a statin or not. However, we know that the LDL lowering with statins will reduce risk. So generally, we're not going to order a repeat coronary calcium scan in somebody who already has a CAC and is on a statin. Now, some research does indicate that statins may slow the rate of the accumulation of calcium buildup in the arteries, but certainly does not reduce it. However, the effect is modest, and statins are not used primarily for the purpose of trying to slow down the amount of calcium. The main goal, of course, of statins is reducing LDL cholesterol and reducing the overall risk of cardiovascular disease. If you have a high coronary calcium score, lifestyle changes and medications beyond just the statin may be warranted. And again, even if statins don't reduce the coronary calcium, their benefits in reducing cardiovascular events are well established. So for individuals with a high score, which again indicates a higher risk of cardiovascular events, statin therapy is absolutely beneficial in reducing that risk. Now, it's also important to recognize that the calcium that we see on a coronary calcium score actually probably represents healed plaque. Calcium generally is an indicator that plaque is healed. It's just that we know that when calcium is present, it also keeps bad company, which is the non-calcified or fatty plaque. Those are the plaques that are more likely to rupture and cause a clinical event. So while statins might not reduce the calcified component of plaques, they can stabilize atherosclerotic plaques and making them less prone to rupture, but they also may cause slight regression of those non-calcified plaques, which we don't see on that type of scan. So hopefully that covers all of the aspects of a really fantastic question. Generally, it is a class effect, and we do know that the increase in LPLA levels with statin therapy is generally modest. There is a spectrum, though, that some statins may be associated with higher increase than others. But again, overall, this is going to be a modest increase, and the significance of this increase is really hotly debated. But I think it's essential to put this in a broader context, which is to say that statins substantially lower LDL and have been proven to decrease the risk of cardiovascular events. So any potential effect of statins, of a small increase in LPLA, is likely largely outweighed by the beneficial effect of lowering LDL cholesterol and cardiovascular risk. So in other words, elevated LPLA is not a reason to hesitate from taking a statin. And in fact, elevated LPLA may actually be an even more compelling reason to take a statin. So great question, but if individuals with elevated LPLA have another reason to take a statin, certainly they should do that. Yeah, this is a very common question. I get asked this all the time. So let's just review some of the data that exists to answer this. There are several studies and meta-analyses. Meta-analyses are particular types of studies that aggregate data from a number of single studies into one large analytic. And all of the data seems to suggest that statins may be associated with a very slight increase in hemoglobin A1C, which is a marker of long-term blood glucose control. This modest increase is more common, though, in those with pre-existing risk factors for diabetes. But what I mean by that is statins will not take somebody who is not destined to develop diabetes and give them diabetes. Generally, the association of statins and diabetes is in individuals who are already on the trajectory to developing diabetes. In other words, individuals who have prediabetes or metabolic syndrome. It may hasten, their trajectory to full-blown diabetes. The effect on glucose metabolism may vary among the different statins. Certainly, high-intensity statin therapy, such as with the atorvastatin and rosuvastatin, may have a slightly higher association with increased glucose levels compared to moderate or low-intensity statin therapy. But again, it's essential to weigh the potential risks and benefits of statin therapy for the vast majority of individuals, especially those at high risk of cardiovascular events. The benefits of statin therapy, that is reduction in heart attack and stroke, are likely to outweigh the potential risks of going on to develop diabetes. The increase in A1C or fasting glucose observed with statin use is relatively small, and for most patients, it's not going to result in a diagnosis of diabetes or significant changes in diabetes management. It's also important to sort of understand in absolute terms what kind of risk we're talking about. So if you're to look across studies, approximately, about 1 in 300 individuals, who take a statin will ultimately have, dysglycemia, meaning that their blood glucose increases, or they may get a hemoglobin A1C that falls in the diabetes range. So it's really quite modest. And then we also need to understand that for every one individual who winds up developing diabetes on statin, in the meantime, we will have prevented 5 to 9 heart attacks. So the math still works out quite well. So we wouldn't hold back from using statins because of the concerns of developing diabetes. No, statins are definitely not recommended during pregnancy or breastfeeding. But I would also mention that a relatively brief interruption in statin therapy during pregnancy or breastfeeding is generally considered completely acceptable. And it's not just statins. I mean, if we look across the lipid-lowering therapy drugs that we have, most of them would not be considered to be safe in pregnancy or breastfeeding. Certainly that's the case for fibrates and Zetia. They're also not recommended during either pregnancy or breastfeeding. There is one class of lipid-lowering drugs that is actually safe and can be used. Those are the bile acid sequestrants. This is a very old class of drugs. People may know them by the name of cholecystilam or cholestyramine, cholestyramine. These are safe because they work in the GI tract. They bind bile and therefore wind up reducing cholesterol levels. But there's no systemic absorption at all, so that's why it's safe during pregnancy and breastfeeding. But the problem, particularly for pregnant women, is they tend to have a lot of gastrointestinal side effects, in particular constipation, which may already be an issue for pregnant women. So even though they're safe, it may not be tolerable. Fish oil, certainly are very likely to be safe in breastfeeding and pregnancy, but they don't lower LDL. So if you're looking for an LDL lowering drug, then that's not going to take care of it. And then we obviously have the injectable drugs now. If we look at the PCSK9 inhibitors, which we've now had since 2015, that would be evolocumab and alirocumab, or Repatha and Praluent. These just haven't been studied long enough. We have very limited data for their use during breastfeeding. So for now, they're avoided. So the answer is really the only class of drugs that can be safely used during breastfeeding and pregnancy are the bile acid sequestrants. Yeah, very important question. For those who have a diagnosis of FH, we certainly can start a statin between the ages of 8 and 10. So 6 of the 7 statins we have approval for use in individuals 10 years or older. And then there's another statin, pravastatin, which actually has approval for use starting at the age of 8. Of course, lifestyle changes are crucial at all ages, but in kids with FH, particularly if there's a very strong family history of very early cardiovascular disease, and or that child has very high LDL cholesterol, we would start kids at 8, sometimes even younger. But the timing should be determined individually based on some of the factors that I just mentioned, and there are many other risk factors that would help to make this decision. But while it's certainly feasible to start and safe to start statins in kids, not every child with FH would necessarily need to start at that age. Yeah, that's a great question. This used to be a very common question, 10 or 20 years ago, when there were theoretical reasons to believe that one might be more tolerable than the other. It's turned out not to be the case. We really no longer pay attention to whether they're relatively more water or fat soluble. And in terms of tolerability of statins, it is actually completely empiric. It's trial and error. There's no way to predict in advance, at least today, which statin is going to be better tolerated than others. So we typically will start somebody on a statin, if they tolerate it, great. If they don't, we can switch to another statin. But we don't make that decision generally based on their water or fat solubility. I would, mention that higher doses of statins tend to be not as well tolerated as lower doses. More potent statins, versus low potency statins may also, make a difference. But overall, it is mostly trial and error. Yeah, statins aren't really directly linked to mental health conditions like depression or anxiety. There are some people who report mild cognitive or mood symptoms like brain fog while on statins. The cause for that is unclear. Fortunately, it's uncommon. So, really what we do in that situation is we'll switch statins or lower the dose, and that often resolves any symptoms that somebody might be experiencing. Well, I can certainly understand why that would be of concern, and hopefully I can allay some of the concerns here. There's definitely no solid evidence of linking statin use to Alzheimer's disease. I would say actually it might be the opposite. There really is some evidence to suggest that statins may possibly help prevent dementia, including Alzheimer's disease, presumably by lowering cardiovascular risk. The small cognitive effects like temporary brain fog that can occur for some individuals while on statins are reversible and are not the same as irreversible dementia like Alzheimer's. So rest assured, statins remain very safe and beneficial for most people. I would also add, you may be aware that the National Institutes of Health right now is sponsoring a very large study called the Preventable Study. This is the largest study actually in the older age group. This is enrolling individuals who are 75 years and older, 20,000 of these 75 and older individuals who have no history of cardiovascular disease. They're not on a statin, and they're being randomized to either atorvastatin 40 milligrams daily or placebo. And the primary outcome of this study is a cognitive one. It's really to see which group will have less Alzheimer's disease, which group will have less cognitive decline. And the hypothesis is that the statins may actually reduce dementia. So we'll have the results of the study in a few years. And of course, if statins are shown to reduce cognitive decline, this will put this whole issue to rest, and hopefully that will be the finding, but we'll have to wait and see. And I would add that there's also a study, very similar study going on in Australia, very similar to Preventable. So in a few years, we're going to have a lot of data with regards to the impact of statins on cognition. So we'll have to wait and see. It's an interesting question. I would say that every statin can potentially have side effects. Some are better tolerated than others due to a variety of factors, like potency, dose, the way it's metabolized. Genetics also play a role in who experiences side effects. But there's no universal best statin. It really requires working with your doctor to find the one that's most effective and most tolerable for you. Yeah, so CoQ10, also known as coenzyme Q10, is a naturally occurring compound that's found within all of the cells of your body. It plays a critical role in energy production, and it also has antioxidant properties. Statins not only reduce cholesterol, but they also reduce the body's synthesis of CoQ10, so that's why this has become, a question. The clinical significance of the reduction of CoQ10 is still uncertain. Nonetheless, this has led to interest in whether, CoQ10 supplementation might benefit people who have, the statin-associated muscle symptoms. To make a long story short, there's really very limited evidence that CoQ10 supplementation significantly reduces those muscle symptoms, and so therefore routine use is definitely not recommended. But, I've come across some patients who clearly find a benefit. There is likely little harm to trying CoQ10 if you're so inclined, although it is somewhat expensive. So if muscle aches develop with a statin, probably more useful to switch statins or adjust the dose more so than trying CoQ10. But you can certainly discuss it with your doctor, to see if it might help in your situation. Well, let's take the flaxseed and flaxseed first, and together, they really do not have significant cholesterol-lowering effects. The dose that you can get with reasonable consumption is far below prescription statins. So while they can be beneficial as part of an overall heart-healthy diet, they're really not potent enough as cholesterol-lowering agents on their own, and have variable quality. But red yeast rice, I would say, is different. It has as its active ingredient something called monocolin K, which is chemically identical to a statin called lovastatin. However, the amount of monocolin K in red yeast rice supplements can vary quite widely between products, which raises concerns about efficacy and safety. And of course, red yeast rice is a supplement and not regulated by the FDA. So to me, if somebody is willing to take red yeast rice, they should be willing to take lovastatin, which will be cheaper, it will be regulated, and it will be more effective. Yeah, this is a great question to end with. I would say that as of now, statins are widely considered as the most effective preventive therapy that we have. We have numerous large clinical trials that demonstrate that statins significantly reduce the risk of first and recurrent heart attacks and strokes by about 35% or more in most studies. They prolong lifespan by reducing mortality from heart disease. And for high-risk patients in particular, they are absolutely worth it. Combined with lifestyle changes, statins are one of our best tools for preventing fatal cardiovascular events and non-fatal cardiovascular events. So they are safe, they're effective, and inexpensive. I would also add that I commonly have a conversation with patients about daily baby aspirin that for years has been promoted as a very effective preventive therapy, prevention of heart attack and stroke. And it absolutely still is in individuals who have heart disease or prior stroke. And it may be still useful in high-risk primary prevention, people who don't yet have clinical heart disease but may be at risk for it. Though the most recent cardiovascular trials have really failed to show a benefit of aspirin in individuals without heart disease. But the issue that I really want to bring up is the fact that I think many patients are very happy to take a baby aspirin but feel reluctant to statins, despite the fact that statins are probably providing much more preventive benefit than an aspirin. And the other issue that I would raise is with regards to safety. Aspirin is incredibly safe in individuals who don't have a history of gastrointestinal bleeding, but they're at least an order of magnitude more dangerous than statins. Again, they're very safe, and this just goes to show you how safe statins really are. Well, thank you for all of those superb questions. I really enjoyed discussing them with you today, and I would encourage all of you to learn more at our website, familyheart.org. And as a reminder, if you need help on your healthcare journey, contact a Family Heart Foundation Care Navigator. Thank you very much.